Greetings, everyone, and welcome to today's CAPE webinar. My name is Dr. Rob Stenstrom, and I'm an emergency physician and senior researcher at St. Paul's in Vancouver. So on behalf of the Canadian Association of Emergency Physicians, I'm delighted to be your moderator for what will be, I think, a very informative and interesting talk today. So this webinar was actually independently conceived by the Scientific Planning Committee, Drs. Eddie Lang, Stacy Kitts, here at Grewal, and Peter Iraculis. My disclosures are as follows, and the other committee members also had no conflicts of interest to declare. This program did receive financial support from AstraZeneca in the form of an educational grant, and we made all efforts to mitigate any potential bias. So just a brief word about the development of and the reason for today's webinar. I think more and more we're seeing increasing numbers of patients on 10A inhibitors. And these have really been practice-changing drugs in terms of the fact that they don't require monitoring compared to warfarin. They have a much lower risk of bleeding than the old school warfarin. But no drug is without any side effects, and there still is a small but non-zero risk of bleeding in patients on these medications. And these are totally, the bleeds that can really scare us. The intracranial hemorrhages, the life-threatening gastrointestinal bleeds, where these patients can be really sick and actually not have a great prognosis. So I think it's going to increase as time goes on. I mean, these medications are becoming more common. The indications are increasing. I saw a paper recently looking at using 10A inhibitors in renal failure, which is something we haven't typically done, valvular heart disease, which has usually been the purview of warfarin. So it is something that we should know about and have an approach to when we see bleeding patients on 10A inhibitors. So to increase interactivity of this session, we encourage you to use the chat feature to submit your questions, and we'll get to those at the end. So we're going to do the questions at the end of the presentations, and we'll try to address as many as we can, depending on how time permits. There are a couple of instances where we're going to be doing audience polling throughout the webinar, and for that you'll need to have access to the Mentimeter website. There's going to be a slide up there to give you the information on that, and so you can access that either through the website or through this QR code. And you'll be prompted at the end to enter the code on this screen to answer each question as it comes up. So now, maybe without further ado, I'd like to introduce our speakers, Dr. Deborah Siegal and Dr. Katie Lynn. So Dr. Deborah Siegal is an associate professor of medicine at the University of Ottawa and an associate scientist at the Ottawa Hospital Research Institute. She holds a master's degree in pharmacology and health research methodology. Her primary research interests include management of anticoagulant-related bleeding, restarting anticoagulants after bleeding, perioperative management of anticoagulation for urgent surgery, and ischemic stroke in patients with cancer. Her research is funded by CIHR, CanVector Heart and Stroke Foundation of Canada, and the American Society of Hematology. She has published over 100 peer-reviewed articles, and her disclosures are as follows. Next up, we have Dr. Katie Lynn, who is an emergency physician at Foothills Medical Care Center in Calgary, stroke physician with the Calgary Stroke Program, and a flight transport physician with STARS Air Ambulance. And she's a clinical assistant professor with the University of Calgary. She completed her FR Emergency Medicine residency training program in Calgary and has a Master's of Public Health from Harvard and is the first CSC stroke certified emergency physician in Canada. Her clinical and research interests include acute stroke care, thrombosis, knowledge translation, and medical education, and these are her disclosures. Maybe I will turn it over to Dr. Lynn.
Thank you so much for that kind introduction. I am thrilled and excited to be speaking with you today. And honestly, I'm fangirling really hard to get to share this speaking opportunity with Dr. Siegal. So we hope that it's a useful session for you. I always appreciate when we are able to anchor our learning in practical cases that we've all seen before or could see in our home emergency department environments. So I wanted to start this talk off with some cases for you to think about and get those creative thoughts going. As we go through these cases, I want you to imagine that you're in your home emergency department on a regular shift about to see some of these patients. So your first patient is a 43-year-old female. She's presenting with severe new onset 10 out of 10 holocephalic headache with vomiting. This started when she was running on the treadmill this evening. There's no trauma, she didn't fall, and she has no history of headaches according to her husband. She does have a history of hypertension, and she has a recent DVT that was provoked by a long transatlantic flight, for which she's anticoagulated with rivaroxaban. Her only other medication is amlodipine. Her vital signs at triage include a blood pressure of 200/115, a GCS of 13, losing points for mild confusion and drowsiness. Otherwise, your examination is unremarkable. You order a CT scan, and this is what you see. And so that brings us to our first question. And again, these questions are going to be the same across all of our cases. I want you guys to log on to Mentimeter, menti.com, and use this code as you see to weigh in on what you might do as you manage this patient. In addition to your standard supportive measures, what would you do specifically with respect to her DOAC therapy? Would you A, not stop the DOAC, B, stop the DOAC but not reverse it? Would you reverse with andexanet alpha? Would you reverse with a hemostatic agent like PCC, FFP, TXA, factor 7, or TXA again, because we love TXA as emerge docs? Would you do something else, or are you not sure? And I'll give everyone a moment here to weigh in with your thoughts. So we're seeing a spectrum. Looks like the vast majority are saying that they would reverse. And whether that's with andexanet alpha or a different hemostatic agent is a bit of a toss-up at this point. And we'll talk about that. That's great. Case number 2. So you're on a roll. This is a busy shift for you. You've got a 67-year-old male who presents with coffee ground emesis and epigastric pain that's been going on for about 24 hours now. He is on apixaban for paroxysmal AFib, and he has a history of peptic ulcer disease. He is on pantoprazole. But recently he's been taking a bunch of ibuprofen for a sprained ankle. He has no alcohol or liver history. At triage, his heart rate is 110, but otherwise his vital signs and his examination are pretty unremarkable. You just note a little bit of epigastric discomfort on palpation. We're going to go ahead and ask you the same question for this patient. Would you not stop his DOAC? Would you stop his DOAC but not reverse it? Would you reverse it, and what would you use? Or not sure, in which case you're in the right place. Again, I'll give everyone a moment here to weigh in with your thoughts. All right, we have an interesting split here. We've kind of got a mix between reverse it, stop the DOAC, but not reverse it, don't stop the DOAC. And I think that this will be an interesting case for us to dive into a little bit later in the talk as we work through some of these challenges, especially with these middle of the ground cases. All right. Finally, you're about an hour out from the end of your shift, and of course, you pick up that last patient you think is going to be fairly straightforward. It's an 82-year-old male who comes in with epistaxis. It's been on and off now for about 3 hours, despite him holding direct compression. He has a past medical history of atrial fibrillation, for which he's on apixaban. He also has a history of hypertension, coronary artery disease with a previous MI, diabetes, and in the past, he's had epistaxis that's required cautery and packing. His medications, in addition to apixaban, include metoprolol, ramipril, and metformin. His vital signs are entirely normal, and you have no concerns about his airway. And we're going to do one final poll, same question, same options. What are you going to do for this final patient of your shift? I think this is great. Again, we've got a toss-up. Some people are not stopping the DOAC. Some people are stopping but not reversing, and some people are reversing in this case. And there's a couple who are choosing other. So this is great. We're going to dig into this a little bit more during the talk. But first, I'm going to hand off to Dr. Siegal to address the question of why we care so much about developing an organized approach to DOAC-related bleeding management.
Thank you so much, Dr. Lynn, and to the CAPE Organizers Scientific Committee for inviting me to present to you. I really enjoy actually being an interloping hematologist. I think a lot about anticoagulant-related bleeding, and I'm really happy to be here today to share some of my perspective on that. And usually these interdisciplinary sessions are often have a lot of really good in-depth discussions that we learn a lot. So I'm going to talk a little bit about why DOAC-related bleeding is such an important thing for patients and their families. And Dr. Lynn's going to advance the slide, so we will hopefully we'll be coordinated there. So as Dr. Stenstrom mentioned right off at the top, in the era of DOACs, we're fortunate because DOACs, or direct oral anticoagulants, have a reduced risk of major bleeding and intracranial bleeding. And so that's a benefit to patients, so improved clinical outcomes. But we still see bleeding at a rate of about 2 to 4%, of patients experience major bleeding every year, and another 10 to 12% experience what we call clinically relevant non-major bleeding. Those are bleeds for which a patient would seek out medical attention by their primary care provider, perhaps in the emergency department. And these bleeding rates vary according to indication and drug and all sorts of things. But this is not a problem that has gone away in the era of DOACs. And it's important to recognize that although intracranial bleeding is the most feared complication of anticoagulation because of its severe morbidity and high mortality, gastrointestinal bleeding is the most frequent single site of anticoagulant-related bleeding. We see a lot of that. You probably see a lot of that. Up to 50% of bleeds are GI in nature. And we do know that as a class, the DOACs increase the risk of gastrointestinal bleeding. Now, there may be some differences between agents, but we don't have data comparing those drugs head-to-head in randomized trials. So DOAC-related bleeding still does limit our anticoagulant therapy for patients. And this slide just shows some of the data from a study that was done in patients with atrial fibrillation, just to emphasize that anticoagulant-related bleeding complications increase the risk of death in these patients. And of course, on the left-hand side, you can see hemorrhagic stroke, 27-fold increase in the risk of death. Subdural bleeding, 7-fold increase in the risk of death. And then we move over to the right-hand side, and perhaps these are bleeds that we underestimate in terms of their effect on mortality. Extracranial bleeding, again, most commonly GI, 5-fold increase in the risk of death. So just to give you a picture of what happens to patients after these bleeding events occur. This is another slide which emphasizes this point. This is a sub-study of the Aristotle trial. This was a randomized trial that compared apixaban to warfarin for patients with atrial fibrillation. And you can see this is a study that took all of the patients who had major bleeding in that trial and looked at mortality within 30 days of major bleeding. And you can see that intracranial hemorrhage obviously has a very high risk of death, 40% within 30 days. But extracranial bleeding here, 9% within 30 days. So think about a patient who, if you're counseling a patient in the clinic about starting anticoagulant therapy, we always review, the potential benefits and harms of therapy. Patients have a 2 to 4% risk of major bleeding on anticoagulants. And then of those patients, the rate of death within 30 days of a major bleed is 9%. Really important information for us and for patients, I think. So this brings us to the, where are we at in terms of managing bleeding? And I always say that, bleeding really does start with prevention. And I think sometimes when we focus on management of bleeding, we focus on the, fancy reversal agents. And I have a research interest in resuming anticoagulants after bleeding. But fundamentally, I think, prevention is really where the money's at. We're not quite there yet. We can identify patients who are at increased risk. We don't really know how to modify their risk very well. And so hopefully we'll see research in this space in the future. But today we're really going to focus on reversal, which includes, early supportive measures and, definitive hemostatic therapies, procedures or surgeries, for example. And then, we'll touch very briefly maybe on resuming anticoagulants after bleeding. And certainly if there's some time for questions about those other aspects, we can talk about those too.
Thanks, Dr. Siegal. I want to come back to our case number 1. Recall our 43-year-old female who is anticoagulated on rivaroxaban for her DVT and presents with a spontaneous intracranial hemorrhage. And really, we're going to be starting here. The reason we're jumping in here is because this is probably mostly where we're getting involved as emergency physicians when patients come in with complications related to their DOAC. And ultimately, these are the 4 key questions that we ask ourselves when we're seeing patients presenting with DOAC-related bleeding. First, how severe is the bleed? Specifics around DOAC details that are going to help us a little bit in our management, which you'll see, whether or not there's a role for reversal, and if we do choose to reverse, which reversal strategy is our optimal one. Beginning with severity of bleed. To be honest, as emergency physicians, we are very good at determining sick versus not sick. And we see patients across the spectrum of severity who present to the emergency department with DOAC-related bleeding complications. Ultimately, the severity of a bleed guides our management of that bleed complication. And we all know that clinical judgment comes first. We've certainly all seen those terrible epistaxises that do become very dangerous or potentially even life-threatening. But this is just a broad guideline to help us understand a little bit more about where different kinds of bleeds tend to fall along the spectrum, and potentially to provide some guidance about how we should manage the DOAC in that setting. So we go all the way from the non-major bleeding, so non-life-threatening bleeding. Examples would include subconjunctival hemorrhages, small bruises or lacerations that we can achieve source control and repair, dental bleeding, self-limited anterior epistaxis, which we may have some approaches for. Hemorrhoids kind of, again, can fall along that spectrum, but the majority of them are not going to be in that major bleeding, life-threatening bleeding category. You get to these moderate bleeds or major bleeding that's not immediately life-threatening, limb-threatening, or organ-threatening. So those are your hemodynamically stable GI and GU bleeds, especially if, again, we're able to get source control. Posterior epistaxis, bit of a toss-up depending on stability, but usually if we are able to get control, whether with our ENT colleagues, IR, or otherwise. And then those life, limb, or organ-threatening bleeds, like our patient, who is her intracranial hemorrhage. Other ones to consider would be your critical sites like your spine, retroperitoneal compartment syndromes, for example, if there is obviously hemodynamic compromise or significant loss of blood. I'll hand it over again to Dr. Siegal to touch on the DOAC details specifically and how they help to guide our therapies.
Thanks. So, and just before we get into that, again, we're emphasizing here, why it is so important to understand what's happening to the patient and treat their bleeding appropriately. We see these data from large phase 3 clinical trials in atrial fibrillation. Sometimes this gets at, what drug has been taken by the patient. We're not specifically talking about warfarin in this talk, but we do see warfarin. And it's helpful just to emphasize that these are clinical trials, again, that compare DOACs to warfarin for patients with AFib. And you can see in the dark blue bars, this isn't a meta-analysis by any means, just to show the rates that occurred in each trial. Deaths from major bleeding events, you can see that the rates ranged from 11 to 14% with warfarin in these trials, and 7 to 10% among patients treated with DOACs in these trials. All that just to say is that, major bleeding and death after major bleeding is still a major issue for patients on DOACs, and that warfarin, which is a reversible medication, still has very high rates of major bleeding and death from major bleeding. So again, we just want to make sure that when we're counseling patients appropriately about reversal and reversibility, that we understand, the data available and what we can do for patients and what some of the limitations are. But it's really important to understand if you have a patient who has a qualifying bleed, which Dr. Lin described, intracranial hemorrhage, life-threatening, organ-threatening bleed, time is, parenchyma, for example. We really want to know, is this person a candidate for reversal therapy? And of course, you're going to be implementing all of your supportive measures that you guys do so well in the emergency department. But it's helpful to know, is the drug present in significant quantity? This is really critical. Probably the most important question that we ask when we're faced with this scenario, and we get called about all these bleeds for reversal, is when did the person take their last dose? Because we really want to know is, what is the DOAC present in a significant quantity? And this is super challenging for us and for people on the front lines. First of all, although as Dr. Stenstrom mentioned at the top, these drugs are great because we don't have to monitor them, like we do with warfarin, but we also don't have established therapeutic ranges. So we don't really even know what level is associated with a clinically significant anticoagulant effect or hemostatic defect. So that's pretty challenging. We know that routine coagulation tests like the INR, the PT, or the APTT that we're all really familiar with and would order for all of these bleeding patients are not accurate or reliable. So they can't quantitate a level of DOAC, and they can be qualitatively helpful, and we'll go into that in the next slide. There are specific tests available that can quantitate the level of DOAC in the bloodstream that are available at some sites, but these are by no means widely available. Particularly, there's limited really to academic centers. We have, for example, at our center, apixaban and rivaroxaban levels. We don't have the others, and those are really with limitations around turnaround time and during the day as opposed to at night, which is sort of when you tend to need them. So this slide shows some of just a summary of the general effects of these drugs on coagulation tests. And you can see on the left-hand side, the column, which includes the tests, the routine ones are at the top, PT or INR, and APTT, and thrombin time, which people are not always familiar with, but is actually pretty routinely available and actually can be pretty helpful in the setting of dabigatran. So let's just maybe work through a couple of examples here. So if we have a patient on dabigatran, less common these days, to be honest, we don't see very many patients on dabigatran, but we know that dabigatran doesn't really have a very significant effect on the PT or INR, but can prolong the APTT, not necessarily, and not in the same way at all sites. It really does depend on the assay that the hospital is using, okay? So it's not very sensitive. The thrombin time is extremely sensitive for even very low levels of dabigatran. So for example, if you have a patient who's on dabigatran and you do a thrombin time and it's prolonged, you know that there's dabigatran present, but it could be a really, really small amount or a really large amount. You don't know because it's so sensitive. The alternative is if you do have a patient on dabigatran and they have a normal thrombin time, well, that's really helpful because that means that there's like essentially no molecules of dabigatran circulating. But let's look at rivaroxaban, which is much more commonly used. We see that rivaroxaban can affect the PT or and INR, but again, not reliably. So some assays are more sensitive than others. And apixaban and edoxaban don't very reliably affect those coagulation tests. So you may have a patient who took one of these drugs, for example, a factor Xa inhibitor, and have normal coagulation tests, but that doesn't mean that they don't have clinically significant levels of drug circulating. So if we look at the bottom three rows, these may or may not be familiar assays to you. The dilute thrombin time and eccrine clotting time are specific or more specific assays for dabigatran. And there's special calibrated anti-10A assays that are used to quantitate levels of the factor Xa inhibitors. Many sites also don't have these available, but sometimes they have another low molecular weight heparin assay. So really challenging. We don't have a test like we have with the INR for warfarin. So, we know that we can use these tests qualitatively, for example. So if we have an abnormal PT or INR or APTT in the right setting, that means that we can probably rule in a clinically significant amount of drug. But these tests are not really sensitive enough to rule out. So we can't be falsely reassured by a normal test. You really do need to interpret the test in the patient that's in front of you. You may know something about your local assay, but probably you don't. And I'm not sure, admittedly, don't tell anyone, I don't really know about our local assay here. The dosing interval is extremely helpful. So when they took their last pill, very helpful. Sometimes you guys don't know that in the emergency room if a person is not able to tell you that information, but if you have that information, super valuable. We know something about the half-life of the drug, and we know something about their renal and liver function, which will help us understand whether or not they likely have levels. If you have specific assays, they're more reliable, not necessarily required. We don't necessarily need to know, if it's 55 or 57 nanograms per mil or something like that, but we kind of want to know, is it there or is it not there? Those assays are not that available. And to be honest, their specific role in this setting is really not well established because we don't have point of care tests. So here we're thinking about when they took their last dose. Timing and half-life is super important. I put up this table just to reflect that these drugs are all cleared by the kidney to a variable extent and the liver to a variable extent. So if those parameters are abnormal, you can expect that there's more circulating drug available. Because I'm a simple gal, and actually so is Dr. Lynn, we like to kind of keep it simple here, 10, 12 hours. These drugs have a short half-life, 12 on the average of 12 hours for most of them. So if you think about, that, it's very helpful. If a person took their drug 3 days ago, they have, essentially zero circulating anticoagulant at that point.
So ultimately, bottom line, timing and specific agent is actually the most important thing for us to determine. If a patient took their last DOAC within the last 24 hours, or the last dosing time is unknown, or they have significant renal or hepatic impairment and are on a prescription for a DOAC and have severe uncontrolled bleeding, then assume that DOAC is still present in significant quantities and err on the side of reversing if indicated. And so that brings us to our next question. Is there a role for reversal? I would say here, really trust your clinical judgment, right? When weighing the risk of ongoing major bleeding against the hypothetical 1 to 10% per year risk of thromboembolism complications for most conditions where DOACs are being used, trust your clinical judgment when bleed management needs to come first. So as in our patient's condition, severe or life-threatening bleeding or critical organ bleeding, obviously ongoing bleeding despite your measures for source control, bleeding with expected long delays for hemostasis. So I run into this more in the transport realm where patients need to be brought in from a peripheral site for definitive control. They may be stable right now, but there's going to be a really long delay as we transport them. And so considerations around that timing. And then less so in our realm, at least not in terms of us making that decision solo, but urgent surgery that cannot be done safely with DOAC on board. If we come back to our spectrum of severity of bleeding to help guide us again in our DOAC management or anticoagulation management, we can again see some guidelines to help us with understanding when we should likely be continuing our anticoagulation despite that non-major bleeding complication, especially if we're able to get source control or if it's a self-limited condition. When we should stop, but not necessarily reverse our anticoagulation as long as, again, we can get that source control and patients are in stable condition, and when we need to not only stop, but also rapidly reverse our anticoagulation to stabilize our patients. Again, our patient with her intracranial hemorrhage falls within this most severe category at present, and so her risk for hematoma expansion and worsening from her intracranial hemorrhage outweighs the underlying indication for her anticoagulation, so we will be reversing her in this particular case. Of course, we also know that there are certain anticoagulated conditions that are much higher risk for DOAC reversal. Mechanical heart valves, we get questions about sometimes in the setting of intracranial hemorrhage on the stroke side. These patients are typically going to be on warfarin, generally is much more indicated in mechanical heart valves over DOACs, primarily just mechanistically a bit different. Warfarin is superior in these patients, but we get that question a lot. And cardiac thrombus. So, post-MI patient cardiac thrombus, now they have a bleed complication. What should we do and how should we balance that risk? I think that in the emergency department, we are aware that these conditions both carry high thromboembolic risk, especially when we compare it to things like atrial fibrillation or DVT indications. But overall, just to put that risk into context, for mechanical heart valves, that thromboembolic risk is about 4% per year not anticoagulated. A little bit less than 1% per year when you do anticoagulate. For cardiac thrombus, it's a little bit higher, so about 20% per year not anticoagulated, 10% per year if we do anticoagulate. But again, the principle is the same, right? Your risk from the existing ongoing known severe life-threatening bleed takes priority and outweighs that theoretical hypothetical risk of thromboembolism down the line if we're having to balance those two things. Dr. Siegal, I'll let you take us through some specific reversal strategies next.
Okay, thanks so much. So this is one of the areas where I end up on a bit of a soapbox. We have, I think, in this space, pharmacological agents for bleed management. And I like to think about these as, specific reversal agents, those that actually reverse the effect of the anticoagulant on some laboratory index and or reduce the level of active drug. And then those that are hemostatic agents, which are strategies to help, support hemostasis while the drug is on board without actually removing the drug or potentially correcting the hemostatic abnormality, the lab hemostatic abnormality. So the de facto reversal agents for DOACs are idarucizumab, which is a specific reversal agent for dabigatran, and andexanet alpha, which is a specific reversal agent for factor Xa inhibitors, actually including the the oral ones, and also enoxaparin. And then for the hemostatic agent side of things, we have PCC, which is prothrombin complex concentrate. So this is a blood product, which you're all pretty familiar with, I'm sure, that consists of the vitamin K dependent coagulation factors 2, 7, 9, and 10. It also has protein C and S and a little bit of heparin. So just good to know that. Plasma, plasma is, in my opinion, not a hemostatic agent, and so it's worthwhile to have it up on the slide, but maybe we should have a line through it. But because, plasma is not given in this setting for reversal of anticoagulant effect. Tranexamic acid, honestly, is used widely to support hemostasis, and we have great data. And then recombinant factor 7A, developed for use in hemophilia patients who had inhibitors to factors 8 and 9, but is used off-label in other settings as well. Not very much data at all for DOAC reversal. So we talked about this a little bit. These are the two agents that truly reverse DOACs. I'm forever correcting the residents as they talk about other reversal strategies. I think they roll their eyeballs at me when I'm not looking, but we have idarucizumab. This is a really easy to use drug, in my opinion, humanized monoclonal antibody fragment against dabigatran. It's actually indicated for both urgent surgery for dabigatran treated patients and life-threatening bleeding or uncontrolled bleeding. And it's given as a 5-gram intravenous bolus. And it actually comes in 2.5-gram vials, but the total dose is 5 grams. Andexanet alpha, not yet available in Canada, will likely be coming to Canada soon, so it's worthwhile for us to have some discussion around it and its data. Human recombinant factor 10A variant, so it's an inactive factor 10A molecule that binds, like a decoy that binds the factor 10A inhibitors. And in the United States and Europe and other places, it's indicated for the reversal of apixaban or rivaroxaban for life-threatening or uncontrolled bleeding. So really important to remember that it is not for use in the perioperative setting. And the dosing is a bit different. It depends on what drug was taken and when it was taken. And so it'll just be important to make sure that there's good communication around in the emergency department around how to dose this drug. So what about 4-factor PCC for factor 10A inhibitor? So right now we don't, I just said we don't have andexanet. It is available elsewhere. We do have PCC, prothrombin complex concentrate. And this is, again, a concentrate that contains these vitamin K dependent coagulation factors. And the mechanism of hemostatic support here is really thought to be that we're supplying coagulation factors to generate thrombin and help stop bleeding. I should just mention here, and we'll talk about it a bit later on, the dosing is really uncertain. And we can come back to that maybe in some of the discussion. People often ask questions about that. Sometimes people give a fixed dose of 2,000 units. Sometimes people or institutions give 25 to 50 units per kilogram. Sometimes people use a maximum dose of 3,000 units as per the product monograph for warfarin. It's very variable, and there aren't a lot of data. And one of the major issues is here that a lot of the data that we have is derived from in vitro studies, like spiked plasma, animal models, volunteer studies, or cohorts without control groups. And so the evidence of actually reversal, like reversing an anticoagulant effect that we can measure with a lab test is really conflicting and quite modest. So I like to consider these as hemostatic therapies. This slide summarizes, now there's a lot of cohort studies that have been done, and there's more coming out all the time. These are a few, you see the middle columns, Majid, Shulman, and Shaw. These are some cohort studies of DOAC-treated patients who presented with major bleeding. On the right-hand side, you see Connolly, which was the Annexa 4 study, which is the landmark study that led to the approval of andexanet. So I just put these few studies here just to mention, these were cohort studies of patients managed in routine clinical practice. They had a variety of different bleed types, but many of them had intracranial hemorrhage. And you can see that there was some variability in dosing. 2 of the studies used PCC. 1 of the studies used APCC, activated PCC, or FIBA. And what I want to call your attention to is hemostasis. So we have hemostasis as an outcome. There are some definitions around this that are accepted. There are some definitions according to the International Society on Thrombosis and Hemostasis about what constitutes, hemostasis. But as you can imagine, it's really challenging to determine hemostasis for different bleed types. So there are different criteria for different types of bleeds, and some are really hard. It's very hard to know when someone stops bleeding in their GI tract if you're not looking at it at that time. But most people achieve hemostasis. There is a rate of thrombosis, which I'm going to come back to in a second. But look at the rates of death here in these studies, 14 to 32%, and that likely reflects the proportion of patients who were treated for intracranial hemorrhage. But although we routinely talk about thrombosis and concerns about administering these treatments for fear of causing thrombosis, we just want to remember that the patients who we're treating are prothrombotic at baseline. These people are coming in sick with bleeding, their coagulation systems are activated. We've now withdrawn their anticoagulant. We're maybe giving them a hemostatic therapy or a reversal agent. They're sick, they're in the ICU, maybe they've had surgery. All of these, factors increase the risk of thrombosis. And so, but we always have to keep in mind the rate of death. So in the Majid study, actually, we saw a 30% rate of death and a 4% rate of thrombosis. So people say, oh, geez, look, PCC, such a low rate of thrombosis, 4%. But many of those patients died before experiencing, or they had an opportunity to experience a thrombosis. So really important to just keep that in mind. I wanted to also mention here when we're talking about thrombosis that in other clinical trials that compared warfarin with plasma for, plasma with PCC for warfarin-associated bleeding, that the rates of thrombosis in the plasma group was around 7 to 8%. Okay, so just to keep in mind that these patients are at risk of thrombosis, but that the risk of bleeding and death from bleeding, which we already have talked about, is super high, and they're actually bleeding. So it's important to treat what's in front of you. And again, this slide just summarizes what I've already said, which is that, in the studies where we've seen these different treatments, idarucizumab, PCC, and andexanet, we see that most people stop bleeding. Great, we're doing a good job, but a lot of people die, and some also experience thrombosis, which to me speaks to the fact that we need to do a better job of restarting anticoagulation when it's safe to do so, and we need to understand better why these people are dying, because they're not all bleeding to death. So it's very important to continue, to understand these and to improve patient outcomes. So we've touched on this a little bit already. For dabigatran, idarucizumab is likely the preferred agent for, if it's available. It specifically reverses anticoagulation, reduces the level of unbound drug. Activated PCC has also been sort of recommended by some guidelines. Dosing is very uncertain. You see that's what those question marks sort of mean. And really, I would only use these if idarucizumab was not available. You can also use PCC, but again, uncertain dosing. At our institution, we have 50 units per kilogram. Other institutions use flat dose of 2,000. Again, other treatments are dialysis. So dabigatran is dialysable. Not sure that I've never really seen that routinely done for patients who are bleeding on dabigatran. It seems logistically challenging unless a person already has dialysis access. Activated charcoal, I think Dr. Lynn's going to talk a bit more about, but seems like not something that's routinely done, at least in my experience. And then for factor Xa inhibitors, a lot of the guidance and guideline documents recommend andexanet alpha, but perhaps there should be a question mark afterwards, maybe preferred for some bleed types, but not others. I think there's a lot of uncertainty in this space, but what we do know is that it does have a labeled indication for reversal, and that, there is this sort of mechanistic component where it, corrects up coagulation abnormalities and reduces level of active drug. PCC is essentially recommended when andexanet alpha is not available. Again, highly uncertain dosing, and activated charcoal is an option if the person recently consumed their drug.
All right. And because I know you're all on the edge of your seats when new literature comes out hot off the press, you're probably asking yourselves about TXA and activated recombinant factor 7 in this setting. Bottom line is these are both of uncertain benefit in the setting of spontaneous intracranial hemorrhage presently, even when given early. So for TXA, the two big trials here are TICH-2 and TICH-NOAC. Both of which found really no difference in functional outcome or long-term mortality. Does sort of shrink the hematoma expansion a little bit in the short term, but whether or not that makes a difference for patients, so far it really doesn't seem to pan out in the literature thus far. Recombinant factor 7, as Dr. Siegal had sort of mentioned, this is a more complex medication to give. We don't give it very often at my center, and we really have very little, if any, sort of reliable data on this. The major trial here is the FAST trial, and it wasn't in the setting of DOAC use, and it didn't find any significant difference in outcomes for patients either. My personal approach for these patients is TXA, if a patient is really, really sick, coming in early, I think it's a a toss-up whether you give it or not. You're not likely harming the patient, but you may not be deriving much benefit. On the flip side, it's not really adding a whole lot of logistic complexity to give because we're so familiar with giving it. We often have it in stock in the emergency department. I would personally not be reaching for factor 7A. It adds to the complexity of managing the case for very little benefit. And then additional measures for us to consider. Again, our focus is always on that good neuroprotection, avoidance of secondary insults with normothermia, normoxia, euglycemia as much as possible. Blood pressure targets are a little bit tricky to pin down, and you'll see different kind of thresholds recommended by different services and different papers. This is the bottom line, really, and the guideline sort of recommended blood pressure target is a systolic blood pressure of less than 140 to 160 to target for the first, usually 48 to 72 hours after a spontaneous intracranial hemorrhage for these patients. Personally, my approach is to target that lower level, that systolic blood pressure less than 140 if a patient is severely affected or unexaminable, so GCS of less than 8, intubated, I can't get a reliable neuroexam on them. If they have a large hemorrhage, which in the literature is defined as greater than 30 cc's or just a significant looking hemorrhage, or if they have a spot sign present, which potentially could indicate ongoing active bleeding or increased risk of hematoma expansion in the short term. I tend to target less than 160 systolic. If the patient is still examinable, can be neurologically monitored, but again, we're watching very carefully because again, this likely is the patient sort of auto-regulating themselves. And there is some recent literature that was published that suggests that that's probably sometimes less is more in that sense, but certainly we know we don't want them to be too high. We do know that if we let their systolic ride above 180, that does seem to be harmful. So this is generally the blood pressure target that I would recommend. And of course, we're avoiding hypotension. My preferred agents are IV labetalol, hydralazine, or if you don't have any of those at your center, enalapril is also guideline recommended too. As Dr. Siegal mentioned, in terms of activated charcoal and its use, personally in the setting of a DOAC-related bleed, this is not one of the things that I'm commonly reaching for. We know that it really only tends to work if we know the patient took their last DOAC dose within 2 to 4 hours. So very, very early presentation, which I think most of the patients I'm seeing are not. And then obviously in the setting of intracranial hemorrhage, you're concerned about neurologic deterioration, possible airway compromise and aspiration risk. So I could maybe envision it if a patient just took their DOAC and then developed their bleed and came in really early, but they were so severe, they were already intubated and had an airway protected perhaps, but it's really not one of the things that I tend to reach for in these patients. I think that there's higher yield treatments that we focus on. And so to wrap up our case number 1, which is obviously our biggest case of the talk, yes, this is a severe bleed for our patient with an intracranial hemorrhage. She took her medication within the last 24 hours. So we are going to assume that the DOAC is present in significant quantity and reversal is indicated given the severity of the bleed and the potential for deterioration. Reversal options, as Dr. Siegal had mentioned. At my center, we don't have access to andexanet alpha outside of a trial environment yet. And so my personal go-to is going to be 4-factor PCC. And at my center, we use an empiric dose of 2,000 for any of these severe cases. It's just an easier thing to kind of logistically simplify a little bit as you're trying to work out all the other complex pieces that need to fall into place for patient management. Okay. So diving into case number 2 next, this is our 67-year-old patient who is on apixaban for AFib and presents with a hemodynamically stable upper GI bleed. Again, how severe is this bleed? So GI bleeds are those tricky entities in that middle ground, right? So not immediately life-threatening at this point in time in front of me, but has a significant risk for deterioration and can go downhill quite quickly. If we consider in this particular patient, I think that there's certain factors that would push me one way or another. Certainly, we're going to stop the DOAC. I think that's not not in question here. The question is around whether or not we then choose to reverse this patient. And I think a lot of that is going to depend on the hemodynamic stability of the patient in front of you, the risk profile of that patient. Do they have liver disease, renal disease? Do they have a history of varices, right? And then your confidence and rapidity of being able to get source control. Do we have a GI suite that's able to take this patient relatively quickly for source control and examination to make sure it's not an arterial GI bleed, for example? When we talk about DOAC details, same as for case number 1, right? So the most important piece here is, when did the patient last take their dose? This patient took it within the last 24 hours. Most of these are dosed once daily or BID. I'm going to go ahead and assume that it is present in significant quantity. And then, as we mentioned, is there a role for reversal? I'm going to let Dr. Siegal address specifically in the setting of GI bleeds a little bit here.
Sure. Just wanted to emphasize that, although we see, severe outcomes after major anticoagulant-related bleeding, and a lot of those are certainly driven by intracranial hemorrhage. Again, GI bleeding is most common. And we see in studies where the DOAC-treated patients were administered specific reversal agents. So in this table, I'm showing the entire cohort and the GI bleed cohort from the REVERSE-AD study, which was the idarucizumab registration study, and Annexa-4, which was the Andexanet registration study. And you can see here that majority of the patients achieved hemostasis just like those in the overall cohort, but that mortality at 30 days was still really high. So 11% in REVERSE-AD and 11% in Annexa-4. And the reason I'm showing you this is because it's helpful to recognize that some GI bleeds can actually be life-threatening, and perhaps these patients are not bleeding to death or exsanguinating to death, but these are elderly, highly comorbid patients, and who simply cannot withstand the impact of a major GI bleed and or have post-bleed complications like thrombosis. But they don't all die of thrombosis here either. So I just wanted to emphasize that fact.
I agree with Dr. Siegal. So again, it's dependent. That question of whether we reverse or not is going to be dependent on hemodynamic stability, severity of the bleed. These are those challenging cases that are very kind of case dependent based on patient risk factors, clinical presentation, and timing basically of symptom onset as well. That's a helpful data point for us. Certainly, we're going to stop the DOAC therapy in this patient, but then whether or not we're going to reverse, again, is going to be dependent on those specific factors. For me, situations where I would reverse that GI bleed is, again, that unstable, hemodynamically unstable patient, as we all know. If they have known varices, severe liver or renal disease in the setting of DOAC therapy, I think I would be much more inclined to reverse that patient empirically. And if there's going to be a delayed, significantly delayed endoscopy or definitive source control, I would be more inclined to reverse that patient empirically as well, even as they sit before me hemodynamically stable. This comes into play a bit more when you're working at peripheral sites or in the transport world, when I'm looking at these very long transport times sometimes, or if there's delays to getting endoscopy done. All right. Reversal strategies are the same as we discussed in case number 1.
Just wanted to mention here that there are recent guidelines by the American College of Gastroenterology and Canadian Association of Gastroenterology that actually recommend, based on very low certainty evidence, that for patients on DOACs who are hospitalized or under observation with GI bleeding, that they really recommend against any reversal or hemostatic therapies like PCC, which is surprising to a lot of folks, and maybe there'll be questions about that. But there's this kind of out, which they describe as selective use may be appropriate in patients with a life-threatening GI bleed who have taken a DOAC within the past 24 hours. So I think our discussion is still really consistent with that, and again, puts it in the hands of the clinician with the patient in front of them. It's important. I just wanted to mention this briefly. Hopefully people are aware of the HALT-IT trial. This was a large randomized trial of tranexamic acid for patients with gastrointestinal bleeding, not anticoagulated patients, but this trial did not show any benefit, and there was evidence of harm with increased venous thromboembolic events. So tranexamic acid should not be used in GI bleeding generally.
Perfect. And so to wrap up case number 2, for our particular patient, he's hemodynamically stable. We're going to consider him in that moderate bleed category We're going to assume that his DOAC is present in significant quantity. And we're going to decide on our reversal based on how he continues to do in our department and how quickly we can get him to the endoscopy suite. So reasonable, certainly, to interrupt his DOAC, stop his DOAC, treat him with IV pantoprazole, get him to the GI suite for EGD, but potentially to hold off on anticoagulation reversal if we're able to get him there quickly for source control. And so for these last two cases, we've primarily focused on that reverse question. Just quickly to touch on the reduce and resume questions with case number 3. This is our 82-year-old male who is on apixaban for atrial fibrillation. He's been trying to manage at home with this homemade splint, as you see. How severe is his bleed? He's hemodynamically stable. We think this is probably something that we may be able to target with source control measures in the ED. I would consider him to be in that non-major bleeding category, but of course, epistaxis is one of those conditions where in rare cases can actually climb up into that major bleeding category. In his particular case, reasonable for us not to reverse him, and actually even to go beyond that and say, if we're able to get rapid source control and he remains hemodynamically stable in the ED, potentially reasonable for us to continue his DOAC therapy. And ideally, we would continue his DOAC therapy if possible, if we can get that source control. There are going to be some cases where it makes sense for us to stop the DOAC therapy for a short period of time. For example, if we've tried to get source control and we just can't, or if he comes in with repeated episodes, maybe that's a patient that we might want to interrupt the DOAC. Very, very rarely are we going to be looking at reversing the anticoagulation effect. But I think the key is if we do pause that DOAC therapy for a patient, it is very important that we have a plan in place for the patient to resume their DOAC therapy when it's safe to do so, or at least to have a plan for urgent follow-up to kind of reassess and decide on when they can resume. I've certainly seen patients who unfortunately have had their DOAC stopped for epistaxis and then have sort of fallen through the cracks and presented with stroke complications. This is obviously not an epistaxis talk, so I won't go into depth too much on epistaxis management approaches. I've got a couple of tricks up my sleeve, and there's certainly lots of resources out there, so I'm happy to address that in the Q&A if it comes up as well. And just briefly, I'm not going to linger on this too long. Most of the time, we're not the ones who are tweaking, adjusting our DOAC doses, but just important, I think, to understand and know that based on factors of age and renal function, there are situations where we're going to use reduced dose DOACs. And this really comes into play when, for example, we're the first ones starting DOAC therapy on a new diagnosis of AFib or pulmonary embolism who's safe to manage as an outpatient, or if patients come in with acute kidney injury on DOAC therapy already. One of the keys that Dr. Siegal wanted to emphasize as well is that in the setting of venous thromboembolism complications, we do not use reduced dose DOACs. This is really for atrial fibrillation. And finally, if patients are requiring urgent surgery, again, most of the time, this is really not going to be a decision that we have to make de novo without any assistance on. If a patient is sick enough that they need that surgery stat, they need that surgery stat, regardless of their DOAC status, and we're going to be looking at reversing. If we have time to involve our colleagues in hematology, internal medicine, anesthesia, and sort of discussion with our surgery colleagues, then we'll have that discussion in patients who are stable enough for that to wait. And this is just to highlight just a couple of those high risk versus low risk conditions from a surgical standpoint when you're looking at bleeding risk in the setting of DOAC therapy. Helpful, again, probably more for our pre-op consultation colleagues, a little bit less relevant from our standpoint, but we can dig into it a little bit more if there are questions. And with that, we'll just wrap it up. Again, recalling our reduce, reverse, and resume framework. Most of the time we operate in this space, that reverse category. But again, keeping in mind that we do have a role sometimes in reducing and resuming DOAC therapy when appropriate for patients that we see. So thank you so much for tuning in, for participating and interacting with us. And we're happy to open things up for questions. I'll hand it back to Dr. Stenstrom.
Thank you so much, Dr. Early and Dr. Siegal, for that really informative talk. So we do have a few questions, and I encourage you to put them through, and they'll get to me. I think it was Grant Innes that once said there are no stupid questions, just stupid people that ask them. But no, that's a little facetious. So we do have a few, and one of them actually is sort of relevant to certainly in the emergency department. This one comes from Andrew, and it's he talks about the prevention of traumatic events, and this is probably one for both of you. What level of activity do you recommend for patients when they come in, say, in atrial fibrillation or DVT, and you put them on an anticoagulant, sorry, a 10A inhibitor, let's say? And, you know, I guess it's going to depend on the, you know, if it's a young person, older person, like, can they snowboard? What activities would you recommend?
Maybe I'll start. As I do this. This is like what keeps the lights on in my house, I think. So putting people on anticoagulants is really helpful to advise them about. I generally start the conversation by saying avoid activities which have a high likelihood of trauma. And I actually, even though Andrew is pointing that out, I do tell people specifically not to climb ladders and to get someone else to clean their eaves troughs. Like, I literally do that. We do, especially for venous thromboembolism, advise people, at least during the first 1 to 3 months of treatment, highest risk time for adverse events, to avoid those activities, like downhill skiing. But if they're going to engage in those activities, really to wear a helmet. But I do try to avoid contact sports, things like that, especially during that first 3 months, because if they do have an injury, then we have to stop their anticoagulant potentially, which could lead to further bad outcomes. So really good point. I do actually do that.
Same for me, avoiding contact sports, avoiding significant heights. So no eaves troughs, no roof work. I've seen a lot of those cases over the summertime, for example. And then things like downhill skiing, downhill mountain biking. My personal advice is to avoid it, at least in the early phases, as Dr. Siegal had mentioned. But sometimes the best you can do is caution them about the risk and make sure that they are always with somebody and that those people know that they're on an anticoagulant.
Great, thank you. There's another one maybe for Dr. Siegal, just the difference between activated PCC and 4-factor PCC.
Oh yeah, really good question. And it's a good reminder that next time I should probably mention that difference during the presentation. So they're both blood product, coagulation factor concentrates that contain the vitamin K dependent coagulation factors and a few other things. The activated form is actually activated in the manufacturing process by like a proprietary kind of process. We don't actually know how, but it includes activated factor 9 and factor 10 factors. So the coagulation system factors are activated, and it was also developed as a product that could be used for patients with hemophilia who had inhibitors to factor 8 and factor 9, because it's thought to be activating coagulation because the factors are already in their activated form. So it's sometimes less available at certain centers. Like if you're not a hemophilia treatment center, you may not have access to it. It's, I think, more expensive than the regular type of PCC. We don't really have data to suggest that it's better than 4-factor PCC, although some people may believe that that's true. There is sometimes also this kind of concern because the factors are activated that maybe it's more prothrombotic, but that also is highly uncertain.
Thank you. And here's the question, again, maybe for both of you. If you had a patient bleeding in front of you and you had a reversal agent available, so say it's either idirucizumab and andexanet alpha when it comes out, would it be reasonable to use both the reversal agent and 4-factor PCC, or is it going to be just the reversal agent?
I'll let Dr. Siegal tackle this one first.
Okay. Yeah, there are like limited data about this. I would not probably use that approach. And actually, if you look at, it'll be interesting to see, one of the things we didn't mention is that the andexanet is being studied in a clinical trial compared to usual care for patients with intracranial hemorrhage. It will be interesting to see what additional co-interventions those patients receive and how they do. To be honest, usually when we administer these medications, I have not often found that there's been a call for additional therapies. I really think, at the end of the day, you're going to be pursuing, definitive procedural intervention to plug that hole in the blood vessel. And so we often don't really see that being even called for. So I would pick one, and the most specific one to me would be the one to use. Although admittedly, because there's no control groups for any of the studies, we don't really know that well about incremental benefit and harm. So it could happen, but I wouldn't usually do that.
Yeah, I think that would be my approach as well. Choose your agent of choice and stick with that one and focus on the other kind of high yield neuroprotective strategies.
Yeah.
This is another interesting question here. is there a plan or is there a test that's a point of care sort of qualitative test for the presence of a DOAC or not? And I remember some of the data from the reverse ad study for idarucizumab, and apparently 20 to 25% of them, when they went back and looked, even though they got into the study, they got the reversal agent, didn't have any dabigatran on board. So, I mean, that would be super useful. Just a yes, no, there's apixaban present or there's not. Is that a thing?
Yeah, same thing actually was found in the Anexa-4 study with like, kind of clinically significant levels of DOAC. People are looking into this. I actually know of 2 different groups. It's just not, it's really been slow in coming. We would love that. And, I've been approached recently to start talking about a study and with some clinical samples. So if you have the opportunity to participate in a clinical study or trial, testing that kind of point of care device, I would highly recommend doing that. It would be really beneficial for us as a community for sure.
Okay, well, that's great. Look, we're right at time here. I think if there are other questions that we can forward them to the speakers, and there were a few others in the chat that couldn't get to. But again, I'd just like to thank very much Dr. Lynn and Dr. Siegal for this super informative talk. And these, this last hour has provided us with some pearls we're going to be able to take into practice. I'd also like to thank everyone who joined today, and the Scientific Planning Committee for their invaluable support, the CAPE staff team for the work behind the scenes, and especially the IT team who've done an amazing job making this come to you in your office or homes. So this has been accredited by the College of Family Physicians of Canada and the Royal College of Physicians and Surgeons of Canada. So don't forget to complete your evaluation to claim your credits, and a certificate of attendance will be mailed out by the CAPE committee together with an evaluation link. So thank you very much again, everyone.